Okay, Dr. Gwendolyn Quinn is Olivia Wan, MD Endowed Chair and Vice Chair of Research in the Department of OBGYN and Professor in Population Health and the Division of Medical Ethics at the New York University Grossman School of Medicine. As a health psychologist and bioethicist, her research focuses on patient-provider communication, primarily in reproductive health and cancer in adolescent and young adults, LGBTQ health issues, uptake of genetic technologies, clinical trials, and access to care for minority and underserved populations. Join me in welcoming Dr. Gwendolyn Quinn.
Thank you for that, and good morning, everyone. I realize I'm standing between you and lunch, and as you're working up an appetite for your lunch, I hope that you'll also work up an appetite for thinking about involving ethicists or consulting your ethical, where's the clicker? Is that this? This?
It is.
Okay.
The big green.
Okay. Thinking about consulting with your clinical ethics committees within your various hospitals. As a reminder, an ethicist is not there to judge you, not there to tell you what to do or right or wrong. We are merely there to support you in making sure that you're aware of all perspectives in a decision type of process, to support your concerns, and to decide when and if risk management needs to be involved rather than ethicists. So what I'm going to do today is talk about some of the biases that are associated with fertility preservation. We're going to work through some cases using a principlist approach. We are not going to solve any of these problems in this time, in this 45 minutes, because they're not necessarily problems to solve, they are just things to think about. So I hope that I'll also raise some additional things for you to think about from a different perspective. So many of you are probably already familiar with the principlist approach. It's one of many approaches that we use to think about things from an ethical perspective. It really considers whether, if in all cases, particularly the patient, but from many perspectives, was autonomy respected? Did this person have all the information they needed to make the decision that was right for them at that time? And then for the clinician, did the clinician act in such a way as to maximize benefits and minimize harms? Did the clinician or the care team refrain from harm? And then what's really at stake with a lot of these issues of fertility preservation is the issue of justice. So justice is that, resources are distributed equally, but we know that that's not always the case because fertility preservation, even in states that have legislative mandates recovering it, still very challenging for people to use their insurance to get fertility preservation covered, to get the storage covered, and to get the ultimate use when they're ready to use it covered. And so this has implications definitely for creating significant health disparities. So just as a reminder, ethics are about what societal norms are and respect for the four principles that I just described. Morals are your own values and your own considerations. And this does take into the idea of conscientious objection. I use a very simplistic scenario. Maybe you don't eat meat, maybe you don't drink water out of a plastic bottle, but if someone comes to you and says, where can I get a hamburger, where can I get a bottle of water, are you obligated to tell them that, or do you impose your own values and say, because I support that, I'm not going to tell you that? It's very simplistic compared to conscientious objection, which is you don't agree with what the patient is requesting to happen or their course of action, but you are required to send them to a place where they can get that information or that care. So, as we've heard in these last couple of days, this is nothing new. One of the top ethical dilemmas that we face with fertility preservation is the lack of financial resources of the patient and the family. But some other things that also rise to the top quite often are what to do with patients who have a poor prognosis, or as we just heard in the last talk, patients have no time, and there can be different perspectives about what time means in order to pursue fertility preservation. We also have multiple cases where either the child and the parent, or in a two-partner situation, they don't agree on what should happen next. And then we have the creation of embryos and some of the ethical concerns that are inherent in that. So this is a little stock photo that says, when you feel overwhelmed, just remember, I can only do today. And many of our cancer patients cannot really take that perspective because they have to make multiple decisions in a short period of time. So today may really be making decisions for 2 years from now, 5 years from now, 10 years from now. But some of the things that it's important for us to think about in terms of whether or not it's a bias or an assumption that we have is that everybody wants fertility preservation. And I recognize there's a fine line between respecting the patient saying, no, I'm not interested, and querying as to why. So sometimes that is seen as paternalistic, intrusive, but sometimes it's actually helpful to uncover why this patient is saying no. It could be because they know they don't have the funds to do this, and they're unaware of some resources that may be available in the clinic. It could be because they worry that they have a hereditary cancer, and they won't outwardly tell you that their concern is that they would pass this on to someone else. So is it good to query as to why without making the assumption that everybody wants this? I would argue yes, because it may uncover something that you can actually provide more information about to help the patient make a decision, but you also risk having that patient perceive that you're not hearing them when they said no. I think we also often assume that everyone, particularly our younger pediatric patients, are going to regret not doing fertility preservation, and we certainly have a good deal of data in the cancer world to know that there is significant regret. But we also have data to know that even among patients who, for whatever reason, didn't do fertility preservation, didn't have time, didn't have money, said they didn't want to at the time, there's significantly less regret among those who had a consultation prior to beginning treatment, rather than finding out a couple of years later that this was an option for them and that no one discussed it with them. We don't need to talk about the affording. I think we're going to beat that horse to death. We often make the assumption that our patients are cisgender, and sometimes they are not, and sometimes they are not out to their families, but they may come out to you in the care team. Also, we make the assumption that patients are heterosexual, and sometimes I've had patients who say no to fertility preservation, and when I ask why, they said, well, because I'm a gay man, how am I ever going to have kids? And when you tell them that there are options, it does make them rethink whether or not they want to do fertility preservation. And many times we find that patients do not have someone else to discuss this with. And if there's a psychosocial team, sometimes that's helpful, but as we heard in our patient panel yesterday, many patients want to talk to other patients who've been in this situation and get feedback from a patient perspective rather than a professional, or in addition to a professional, I should say. So our first case is Jenna. She's 28 years old and engaged with a new diagnosis of sarcoma. She lives in Nevada. She lives in a state that does not have any legislative mandated coverage for fertility preservation. She has no health insurance. She's being treated on Medicaid. Very interested in fertility preservation. She's going to have surgery and chemo. No savings, no family, and both she and her fiance are unemployed. So I'm going to show you a multiple choice, and since we don't have Mentimeter here or a Zoom poll, raise your hand, and you can raise your hand more than once. What would you do in this situation if you were counseling this? Would you, A, focus on grieving the loss of opportunity for this patient? I'll read through them and then we can vote. B, direct them to financial counseling. C, contact philanthropy. Or D, send them to REI and let them figure out the finances. So how many people would vote A for focus on grieving the loss of opportunity for this person? No resources, no money. No one? Okay. Direct them to financial counseling within your facility? Okay. You can vote, like I said, more than once. Contact philanthropy, see if anything's available. Majority so far. Send them to the REI, let the REI clinic figure it out. I know many of you would really do that, but yeah. Okay. So yeah, if you struggle to think about what you would do because you're unaware of if any of these resources are available within your institution, I encourage you to find out. And if they're not, connect with other navigators or other teams to find out perhaps how you can create them in your institution. So in thinking about the counsel, we always think about how would we counsel, where would we refer? Many of you come from a variety of different settings, but there are some states in the United States, I think there's at least 2, where there are only 1 or 2 reproductive endocrinologists in the entire state. So getting a patient to REI, it's not practical, especially if they have a limited amount of time before they need to begin treatment, and especially if they have no financial resources to travel. Sometimes even traveling 1 hour away is more than a patient can handle. So thinking about what are her options, what are his or her options, what are their options, considering the autonomy. Have I truly given this patient all the information that they need to make the decision that's right for them? Have I considered all options that are available for them? And I really want to emphasize this point because I'm still reeling from the shock. Kyle Stimpert and I were at PSYOP, the International Pediatric Oncology Conference, talking about ethics and fertility preservation. And a pediatric oncologist from the United States stood up and said, I do not talk about fertility preservation with my pediatric patients and their families because they can't afford it. And it feels very unfair to talk about this option when I know that there's no finances. And she did come from a very rural state, a very conservative state with perhaps limited options. And so this was really heartbreaking to me to think in 2023 that the autonomy of the patient and the family is still being taken away in some circumstances because they're not being given this information. So our next case is a 35-year-old diagnosed with stage 4 pancreatic cancer, married 5 years. They've been undergoing IVF for 5 years unsuccessfully, but now they want to bank embryos and store them specifically for his wife to use, not after her death, after his death, after the husband's death, knowing that he's not going to survive, and this is the plan that they have for their family. What would you do in this case where the patient is asking for your help as a cancer patient to help him and his wife create these embryos? A, send them to the REI and let them figure it out. Request a psych consult. Nothing to do, this isn't my business. Or counsel against this option. So how many would do A, send them to the REI, let them figure it out? Couple people. Request a psychiatric consult. Couple more people. This isn't my business, there's nothing for me to do. This is their decision. Nobody, okay? Actively counsel the couple against doing this. Nobody there either. So obviously, this is maybe a little bit easier task to think about. This is a married couple. They've been actively involved in IVF. They probably have already signed consent forms within a clinic. They've made their wishes known. They're clearly making an active decision about what will happen after this patient's death. And it's a little different when this is a pediatric case and the parents of the 16, 17-year-old are requesting the child to store gametes that they intend to use, and they want those gametes gifted to them. Some clinics have automatic policies, which are important for patients to be able to know up front. At the Echo Torch program, we've had several calls with mostly pediatric nurses saying, we counsel our patients about these options, and then we send them to the clinic. We don't have a dedicated REI that we send them to. We give our patients a list of places to go, and then they get to the clinic and they find out the options that we counseled them about are not actually available to them. And I think that is some of the challenges sometimes with creating patient education materials. You can list all of the fertility preservation options or list all the things that one might do, but depending upon your state, depending upon the clinic, depending upon the age, they may not all really be options for you. So we used to joke many years ago that, one of the options was, on a list of fertility preservation options was a radical trachelectomy. And some of our patients would read this and we joked it was like a menu. I'll take the radical trachelectomy with a side of fries. That's not an option for you. You don't have cervical cancer. And patients often can't discern which options may or may not be relevant for them. So it is important, I think, as you're counseling, to caution patients and their families that when they get to the clinic, they may find a different set of options, a more limited set of options, and long-term outcomes may be available to them. I don't see a timer anywhere. We're doing on time. You have 20 minutes. Okay. So next we have Fabio. He is a 21-year-old with testicular cancer. He has a good prognosis for his disease. He's in college and lives with his parents. He does not want a sperm bank, but his parents desperately want him to do, and they offer to pay for everything. He continuously says no, and we asked why. He's like, I just have never wanted children. So what do you do in this situation? You ask to speak to the parents alone to remind them that it's his decision. Ask to speak to him alone and tell him he may regret this when he's older. Send him to social work or psychology for the whole family to have a consult, or something else. So how many would do A? Talk to the parents alone and kind of get them to back off. Not too many? Okay. Talk to him alone and tell him he may regret this. A little bit more. Send for a family consult. Talk about this as a family a little bit. Something else. Okay, and when we have the question, please tell me what your something else is. So this is a challenging situation. This is clearly an adult, not a minor, able to make decisions, maybe hasn't had life experience. But I think it's interesting that this person has said, despite all that's available to them when finances are not an issue, that he has never wanted children. And we may think differently about males banking sperm and never returning to use it than we think about females banking eggs or tissue, never returning to use them. But there's a fine line here between respecting the autonomy of this patient and his wishes and some of the wisdom and the knowledge that you all have from working with these cases for many years and knowing that regret is possible. Some people feel comfortable saying, you know what, just bank. If you never use it, you never use it. And other people would feel that's an issue of justice. That's a waste of resources to have the patient go through this, have anybody, whether it's his parents or charity care, pay for this when they have no intention of using it. So now we're going to move on to some more ethical type of issues. And again, regardless of what your politics are and how you feel, I think that these are really real issues that are significantly impacting the oncology community. So what are embryos? Are embryos baby? If I pick up an acorn seed and toss it in the gutter, have I thrown away an oak tree? Or have I thrown away an acorn seed? I don't expect us to solve that today. You don't even need to share your opinion. But we do see that many states are moving towards the consideration of embryos having personhood. And this is a really significant issue in oncology. And I really want us to think about it. And I want us to think about commentaries and types of things that we can get out there as a community, and patients who feel willing and comfortable to testify what this means for them. So the overturn of Roe and the Dobbs decision has already been shown to have impact for people with cancer. We've already had one case of a pregnant person with a wanted pregnancy with a cancer diagnosed in the second trimester, in which the type of chemo that this patient needed that was life-saving, has a black box warning, cannot be administered to a pregnant person, living in a state where abortion beyond 6 weeks was not a possibility. And so this person had to delay their treatment to travel to a state to end a wanted pregnancy in order to continue their own life, to hopefully have another child in the future. So we know some states are restricting abortion past 6 weeks. We know that some states, the last two most recently, Texas and Louisiana, that passed legislation requiring coverage of fertility, do not allow the ability to create embryos, which I think does restrict the autonomy of particularly of patients who do have hereditary cancer or a disposition for hereditary cancer, to kind of know what they're preserving prior to preserving it. And I know that this is a debatable thing, but if you're under the age of 38, you may have a better chance of, in the future, taking home a baby if you are allowed to preserve an embryo. So this is the most recent state. I understand there was an election last night. I don't know if that changes the color of Ohio. You all have to tell me. But this is a map of the restrictive abortion states. And you can see that the very darkest color represents those states that are the most restrictive. And this is changing in some ways. New legislation's being proposed that are easing restrictions, and at the same time, other states are proposing even more restrictive legislation. And so I thought that this commentary in JCO was really important, and it talked about rewriting women's autonomy, for lack of a better term. I know that's not inclusive language, but for people with uterus and ovaries with cancer care. And specifically, they stated the impact of this ruling will be dire for vulnerable female patients of childbearing age by limiting their standard treatment options, their ability to consider clinical trials, and access to cutting-edge treatments. So we already know that pregnant people often get excluded, or people with reproductive capacity are often excluded from clinical trials because of that. This will increase even more their potential opportunity to participate in these new treatments. I'm going to show you some headlines that to me are very disturbing, and I want to really point out that this is 2023. In March of this year, a judge ruled, using a century-old law governing the treatment of slaves, that embryos could be considered property. In 2023, as recent as September 2023, Alabama courts were considering whether or not it was manslaughter that a lab technician accidentally dropped a dish of frozen embryos on the floor, and if this was potentially a wrongful death in which a suit could take place. So, and again, this headline speaks to the state bans that are preventing cancer patients from getting chemotherapy that has a black box warning. It's not that these drugs are intentionally biased against pregnant people. It's always been the FDA warning, this drug cannot be given to a person who is pregnant. We know in some cases there are alternative drugs that can be given that are safe to give in pregnancy, but sometimes it is not the most efficacious drug for this type of cancer. So, we had these debates at ASRM, we've talked about them in various circles, but the ability to make decisions about the use of assisted reproductive technology is being affected by the Dobbs decision. So we know that IVF is critical for patients, or ART is critical for patients, not just with cancer, but with other serious illness. And these two laws, two states have the laws prohibiting embryos from being created unless they're being planted immediately. Louisiana and Kentucky had these prior to Dobbs' decision, and now Texas has this post-Dobbs decision. And who knows? We're coming up to an election. Who knows what's going to be on the forefront? We have to continue to consider the legal landscape of where our patients are being treated with regard to our counsel. And I think we have to continuously fight for the lack of autonomy that is being respected as the walls, I will say, are closing in on options for patients with medical conditions, whether that be cancer or transgender patients seeking gender-affirming care. So I would like to pose these questions as we kind of near the end of this. How do you counsel patients, whether you are a reproductive endocrinologist or a patient navigator, when embryos may be best, when maybe they should use PGT, when the patient's over 35? Do you talk about donor sperm being an option? Do you talk about the fact that, yes, you're in a relationship now, but this relationship may not be a good relationship 1 or 2 years from now? If you have the option to counsel to bank both eggs and embryos, do you provide that counsel? Do you bank both? And what if finances are restrictive and that is not an option? And what are about the options, and we talked about this already some of today, for a patient who's over 38 to bank ovarian tissue? So I'm curious to think what you learned today, and I won't ask you to vote. Did you learn nothing? Did you think about new options for ways to counsel patients, new ways to think about old problems, old ways to think about new problems? Because I would argue, this is my personal opinion, it is no longer our body, our choice. We have lost choices over what we can do with our bodies if we have uterus and ovaries. And with that, I'll stop, and I'm happy to thank the Oncofertility Consortium for having an ethical case, and I would love for us to do similar in the future to what happened in the session prior to this, where we have a point-counterpoint, a pro and con on some of these considerations. Thank you.
Thank you, Dr. Quinn. Okay, so I just want to say that I learned of new problems, is what I learned. All right, Julie.
Thank you. Great talk. Question for you. So sometimes when patients were contacted and referred by their oncologist to do fertility preservation, and we have our amazing navigators that call, give some options so they understand what the visit's going to be about. And right at that moment, they decline. They don't even want to make an appointment with us. And so what would you recommend for our navigators or the people that are kind of on the front lines of how to approach that, with being able to respect autonomy, but also make sure that some of these barriers or biases that maybe, or things that the patient's concerned about can be addressed if we have those options for them?
We talked about that with our ECHO group. Patients often have no idea who you are, as a reproductive endocrinologist, why they're having an appointment with you. At a place where I used to work, we used to have an intake form that says, do you have all the children you wish to have? Would you like a referral to a reproductive endocrinologist? We had 70-year-old men checking yes, they wanted the referral because they thought that was how they got Viagra. A lot of people don't know what a reproductive endocrinologist is. They don't know why they should go. You can imagine that sometimes the oncologist had a very limited time, if at all, to have a discussion about that. And sometimes they would think, like, I have, 5 appointments today. Which one do I absolutely not have to do? And maybe it's the fertility consult because, they don't realize that. So would argue it would be great if we could hand patients materials that explained, and maybe you don't want to have the appointment on the time that I've set up for you, but contact me at another time when you feel, ready to do that.
Thank you, Dr. Silber, and then.
I'm in Missouri, which is a pretty red state, and 2 things that our lawyers have made clear is that the original Roe versus Wade was just a brilliant decision that should have satisfied all religions and all secular people. It was absolutely an incredible balance and really brilliant. Before Dobbs, Missouri actually passed a law that it was a very severe law making abortion illegal. On the other hand, when we looked at it, there was a rider in that bill that specified that embryos were not people and embryos were just personal property. So if we dropped an embryo, we wouldn't be liable. And furthermore, in that bill is that we could refer people to other states, like across the river to Illinois, to get an abortion. So it's very spotty, but despite it being a red state, somehow or other we don't have the problem. But it's shocking to me because I've really studied this, and Roe versus Wade was just a brilliant decision that never should have been a problem for any particular religion, other than if they just, these guys are crazy.
Thank you, Dr.
From
Silver.
your mouth to their ears. Yeah.
Thank you for giving such a great presentation. I am one of the fertility nurse practitioners at Memorial Sloan Kettering, and I speak to so many patients who can't afford fertility preservation. So on the first case presentation, the female from Nevada who had a new diagnosis of sarcoma, one of the options was focus on grieving the loss of being able to, undergo fertility preservation. And I did raise my hand late, and I just want to defend it. I speak with so many patients who, despite the philanthropic resources that we give them or tell them about, or despite recommendations and counseling and access to care, because we really try to cut through a lot of that for them and help them to get to the REI, help them know about Chick Mission or Verna's Purse or what have you. They still don't pursue it, and I find on a lot of my follow-up calls of patients who really, really wanted to do that, this on the first visit, don't return my calls, or the ones that I do were like, I didn't want to tell you, but I'm not going to do it. And I think there's a lot of shame in not being able to afford these things, and the realistic part of it is a lot of our patients are not going to be able to undergo these options. So I think along with being able to grieve the loss, I of course would offer philanthropic resources, of course refer them to fertility, financial and counseling, but I think we also have to remember the psychosocial component of this and remember that many of the patients are not going to be able to afford it, or maybe they look at the storage fee and they say, even if I get the grant, I can't afford $500 a year or $1,000 a year going forward. So I just feel like that's something that we should keep in mind as the people who are speaking directly with these patients, that we can also help them more in that loss and let them know that they're not the only ones that can't afford this. This is a huge gap in our healthcare system. There's no shame in it. So I just wanted to defend that.
Yeah, I think that's a really important point. We sometimes have patients who come to that conclusion and they say, oh, well, I really want kids, I'll just adopt. And it always catches my breath to want to say, adoption's hard for everyone. It's going to be especially hard for you until you're 5 years, if you're doing a public, adoption, not private adoption. 5 years cancer-free with a note from your oncologist. But you don't want to take away every last bit of hope. The other things to talk about, yes, it was ideal if you could do this now, but who knows, by the time you're finished treatment, by the time you're ready, what options might be available, what fertility you may have, whether that's false hope or not, I don't know.
Hi. First of all, thank you for this amazing talk. I practice area in Israel, so all the role regarding abortion is very different there. And I'm here for almost 1.5 years, and it was just after this rule passed. And I'm amazed in a very bad way every time I hear about it, because the ramifications are much bigger than what I heard the new law. I was shocked, but I was, okay, this is very bad, but now that I see that it's ramification about the mother health even. And in Judaism, even if we are more conservative, the mother health is beyond everything. So, and when I was here, I was in few social groups, like physician mom from Pennsylvania, I will say I'm there. I still raising concern about people asking for friends that are also physicians from different states and say, okay, she has a twin pregnancy or one of the baby vanished pregnancy, and she's looking for an abortion and it's not allowed in her state. Can we help her? And I think that there is something that is starting to be, it's like physician helping physician to have better care. And I was wondering if this is something that as a physician community, we can think about it, about having, because there is such a difference between different states, having maybe, I don't know, maybe some network or something that as physician, not only for physician, but for the general population, to help as this care from one state to the other. And if I think about equity, it's not going to be equity because it's going to be cost money, and exactly the poor population will not be accessed. But I think that maybe as Oncofertility and looking at the fertility of the different women and the breast stratification, we can think about something that we can do.
So the thought is there some sort of network that we can create as a consortium so that we can support patients and physicians who are in states who are having these challenges? Is that the point? And I think that's a point, and I think that's something that we should continue to discuss. We don't have that. I think we all reach out to one another as we can, but we don't have something that exists. But I think that's a very thoughtful consideration and something for us to consider as a community. Thank you for that.
Thanks, Gwen. I really feel like we could have had like a snippet of ethical discussion for every single session we have at this conference. One thing I really struggle with is the concept of autonomy in pediatrics, because I feel like particularly for adolescents, where we know that they're not great at thinking about what their future wishes are going to be, and there's such a short period of time for them to be making decisions about fertility preservation. I just worry a bit that we lean a little bit too much on this concept of autonomy and take that initial quick decision and move on, where we know the literature really shows unilateral regret for people who don't preserve and not really regret. Even if people aren't utilizing their samples, they're not coming back and saying, I regret storing those, particularly for sperm banking. Mm-hmm. So I was curious if you had thoughts about that.
Yeah, I think that's a good point. We know that, the frontal cortex is not completely developed even until you're 26, so, let alone 7, which is the age of assent. 7 years old and up should assent to things while parents consent on their behalf. We've also, in the literature, there's a lot of perspectives supporting parents making these decisions on behalf of their patients. But I think it's really challenging when the child, and the youth, a 16-year-old, is actively saying, I do not want to do this. I refuse to do this. I will not sperm bank. And you can talk all you want, and you can, sing I told you so later. I think in those situations, it is best for some counseling to happen outside of the dynamic of the family, because sometimes it may just be, I don't want to do anything my parents want me to do. Yeah. And so, having a conversation with an uninvolved adult, can be helpful. But also peers. I mean, I think if we can, older peers, if we can collect testimonies from people that say, I regret not doing that. I do have a case. I always tell this case of this kid who was 16, refused to sperm bank, got married very young. Their marriage ended as a result of infertility. He was azoospermic. And he got very angry at his parents. He's like, you made me study for SATs. You made me brush my teeth. Why didn't you make me do this? Like, how do I make you produce a sperm sample when you have actively said no?
Yeah, and sometimes I think one of the biggest hurdles is we're in such a time crunch, and so you just don't have the luxury of having those ongoing discussions to get people all on the same page and get them to think about future regret. I have 2 other comments, and then I'll sit down. One is that we have a real disparity across populations too. So a lot of those philanthropic organizations are specific to cancer, and we have a lot of populations now that are not getting served, and we need to think through as a group how we want to tackle that. And then the last thing is that Ohio did get a victory yesterday. So
Thank you. Yes, one final question.
I also like your idea, Lena, that you've mentioned before, that is particularly for sperm banking, if it becomes standard of care, at some point it would be just like, and you're going to go to the blood bank and have your blood drawn, and you're going to go to the sperm bank, and so kind of like the whole decision process is not presented as a decision, but just that this is the course of action.
Although I would have to say there are some children who are just very uncomfortable with the idea of masturbation and really don't want to embark on that part, that part of development.
Yeah, and some religions and cultures that would support them being uncomfortable.
Yeah. Thank you. Last question.
Ellen Greenblatt from Toronto. I found this fascinating. It's terrific. And I do happen to be in a province that does fund fertility preservation, so we're very blessed in that way. The part I find the most difficult is patients with a very poor prognosis. So, first of all, I'm not an oncologist, so I kind of know oncology. I usually have a feeling when this sounds really bad, but A, I'm not an oncologist, and B, it's not my role to talk about the prognosis of their oncologic diagnosis. So I think what I find difficult is when it really hasn't been discussed and the patient is sent to talk about whatever it is, usually egg freezing, but other things. And, and then in the background I say, what is their prognosis? And they say, they have a 5% survival rate or something. And that I find really difficult. And, I do say it's not my role to talk about, going, because it's not insignificant to go through stimulation and harvest, especially with a young person. So we had a case on Friday, the day right before we came here, 14-year-old with a perineal sarcoma, 14-year-old girl with a perineal sarcoma, and they're talked about fertility preservation, maybe taking an ovary and freezing it. She's still undergoing her workup. So we talk to her as she goes through her workup. They find out she has bone mets, and it goes worse and worse and worse. And we've already met her and talked to her family about ovarian tissue freezing, and they're pretty motivated. That, to me, is the hardest place to be.
Yeah, I think, we heard earlier, I think someone mentioned that the parents donated the tissue and we're very happy that they have done it, that their child did this and can contribute to research even if they didn't survive to be able to use it themselves. I've had the reverse case of parents being so relieved that they didn't do testicular tissue cryopreservation because they would have felt like they needed a second burial, a second grieving for this tissue. So I think, presenting these options that we would present to everyone. Because any of us, regardless of the cancer diagnosis, might not be here tomorrow. But talking about in the event you don't survive this, just understand our clinic's policy is, most cases, if you're a minor, if you die, your tissue is destroyed or donated to research, if that's an option. And make sure that the family unit, that really sinks in, at the time. Because even though they hear a lot of things, they're signing a lot of papers, they don't know that the nuances of those kind of things really register, as they're thinking about it. We've had parents come back to try to get their child's stored gametes when they clearly signed a form that said that they were going to be destroyed upon their death, and they're arguing, and they're saying, well, I'm going to go to court, to get this. So I just don't think everything registers in this moment of chaos.
And I also think that we do have opportunities to circle back. I know there's a time crunch, but if we meet with the patient and we're not sure that they understand what the prognosis is or how poor it is or is not, we can still do the very balanced discussion and then circle back with the oncologist and say, when I spoke with them, I wasn't sure and it wasn't my place, but please be sure that the patient understands that just for their oncologic care. And then discussions can still happen after our consultation, but I agree that we have to be very balanced and not lean one way or the other. But it's not the end of the discussion necessarily. Thank you, Dr. Quinn. All right. So it has been my immense pleasure to be the moderator for this session. We will now adjourn for lunch. Please remove your posters before 1 p.m. if you have them, and we'll see you back here at 1 p.m.